in the last few years, quite a significant amount of money to research both in traumatic brain injury and in stroke. But there are very many hurdles to be overcome between that research being funded, it being completed, and then it being implemented into practice to help all of you people with brain injury. So this session is going to focus on how we identify best practice through developing guidelines and clinician surveys, and then how we go about evaluating the implementation of rehabilitation programs. So the Medical Research Fund is certainly contributing to that effort. It's funded projects that identified what would be the most important outcome variables and predictors of outcome. It's also funded, in a minute, yeah. It's also funded a number of guideline projects. So the mild TBI guidelines will actually be released in a few weeks. They're led by Karen Barlow. It's funded guidelines for physical rehabilitation, which were released last year. And it is funding the development of guidelines for psychosocial rehabilitation, which Cynthia will be presenting something about that today. And so they've recently also funded a study. Oh, no. Go back? Okay. Which I'm actually leading and I'm very excited about. So I very much wanted to tell you about it because I'm going to be seeking all of your help. So this is a 5-year project that is going to be investigating from the perspectives of people with brain injury, their families and carers, clinicians and healthcare managers, what are the needs and barriers to delivering the best care we can for the cognitive and the psychosocial problems, that is the thinking problems, problems with behaviour, mental health, sexuality, all the things we were talking about this morning. And then based on the feedback from all these people, which will be sought by people like just Trevena Peters, and there's about 30 investigators on this project, we will try to develop resources, develop care pathways, and importantly, we're going to try and do this all around Australia. So that includes groups that have particular needs, such as people in rural and remote areas, people from culturally and linguistically diverse backgrounds, and Aboriginal and Torres Strait Islander people. So the Aboriginal and Torres Strait Islander component is being led by Hayley Williams at University of Queensland and will be conducted initially in large part in the Northern Territory, but we will hopefully extend the resources to Aboriginal people all around Australia eventually. So once we have rolled out those resources, people like Mark and Peter Bragg and other people on our team will help us to evaluate how effective that has been and whether it really has made a difference. So I'm incredibly excited about this. It's a 5-year project, but we are going to be very much seeking your help. First, you will get surveys in the coming months, whether you're a person with brain injury, a family member, or a clinician. And we would really be grateful if you would respond to those surveys. I know you get lots of surveys, but unless we get your responses, we won't be able to make change. So, without further ado now, I'm going to move on to introduce first Mark, who's going to offer some pearls of wisdom about implementation.
Thanks, Jenny. Many of you may not realize, but a lot of people who study research and how long it takes to get into practice have found that it takes between 7 and 17 years for people to get any research into practice in general practice. And furthermore, it's really hard for people to keep up. If you were in your field, on average, you'd have to read 25 papers per day, 365 days a year to keep up in the field. It's really, really hard. So we have been very involved in guidelines, as you heard this morning, and using this model, which for those of you, I'm sorry if you're over that side of the room, I'll use the laser, this one. But basically, this is called the knowledge to action cycle. It's a way of thinking about how do we get evidence into practice. It was developed by my colleague Ian Graham and Joe Logan, who are from Ottawa in Canada, and another group. What they did is they synthesized all the previously published models for implementation. And so I'll just orient you. In the middle, you have the funnel. The funnel is really taking knowledge that somebody did and packaging it and tailoring it to knowledge, tools, and products that people can use. And we're going to hear from Cynthia and some of our other speakers today about what they're doing to make evidence more accessible to people. Another part of the thing is to ask, do I have a problem? Is there a problem in my practice? Is there a difference between what I'm doing and what the evidence is saying? And so the cycle really starts here, that I really am not sure what the quality of my treatment is right now. And so some of our speakers are going to talk about this issue. So then you say, okay, I would like to improve the quality of my activities. I'd like to implement some of the evidence. And so, but then you come up to the fact that we're doing implementation in Australia, and Australia has rules and regulations and policies and structures and various things that decide things. And so you have to adapt that knowledge to that context. And so we're going to hear from Jessica and others about the barriers that people perceive to using the knowledge. And then you have to decide, okay, how are we going to actually implement it? You have to tailor it to the barriers you identified. And then once you get it going and you start to get it into practice, you have to monitor whether people are actually using it and evaluating the outcomes. And then you go through the cycle again and again. And in the meantime, we're still synthesizing new evidence. And so the important thing for today, and it was Nick and some of the others thought it would be nice to put this group together, because we're going to be talking about really quality of care, the gaps in practice, and what we've learned so far. So without any further ado, I'm going to hand it back to Jennie, and we'll start with our speakers. So thank you for your attention.
Okay. All right, so the first speaker is very well known to me, Jessica Trevena Peters, occupational therapist and clinical neuropsychologist from Monash University.
Thanks everyone. Today I have the pleasure to present our international survey results of current clinician practice of cognitive rehabilitation after traumatic brain injury. And this is just really the first step in a larger body of co-design work that we're doing to try and improve practices, experiences and outcomes within cognitive rehabilitation. So, cognitive functioning is an important focus of rehabilitation after moderate to severe traumatic brain injury to promote independence and engagement in activities and relationships. But despite recent clinical practice guidelines, the INCOG guidelines that we heard about from Mark this morning being released, the current state of practice remains somewhat unclear. Understanding this will ideally help us in bridging this knowledge to practice gap and informing the means to do so. So, our team designed and distributed a survey digitally last year over 6 months, and participants could actually complete this in their choice of language. Areas of the survey included practice of cognitive rehabilitation, contextual factors and barriers and facilitators. And data were analysed using descriptive statistics and content analysis. We are incredibly grateful to those who participated or snowballed the survey, and in response, 605 clinicians were included. We reached 51 countries, and despite a disproportionately high representation from Australian clinicians, sensitivity analysis actually revealed unchanged results when Australian clinicians were excluded, so today I'll report on the larger sample. Respondents had a nice range of years of experience and included a number of disciplines, with highest representation from occupational therapy, neuropsychology, and speech pathology. So moving to our results, well, clinicians were actually asked to rate their frequency of use of cognitive rehabilitation approaches and to describe these qualitatively. So environmental compensatory adaptations were the most commonly used. Qualitatively, this included adapting the task or the environment or use of a support person. Next came external compensatory approaches, for example, using a calendar, an electronic organiser or a note-taking structure. Repetition was the third most commonly used approach. Internal compensatory strategies followed, and within this, metacognitive approaches were most commonly described. Abstract restorative cognitive retraining was least commonly used, and this could include pen and paper and computer-based training programs. Additional approaches were also identified qualitatively, and these most commonly included instructional approaches to aid learning or functional skills training. 4 main elements of cognitive rehabilitation were also identified qualitatively. Firstly, assessment could include brief screens or more comprehensive evaluation, and formulation of this assessment was used to guide treatment planning, and psychoeducation commonly followed. Goal-based rehabilitation was frequently reported, and although it was less common, some clinicians did say that they used SMART goals or goal attainment scaling. Next, support network and the rehabilitation team involvement were frequently described, and these were noted to be very beneficial. And feedback and progress monitoring were also noted by the respondents. So, whilst cognitive rehabilitation practice guidelines provide recommendations by cognitive domain, in practice, 71% of our respondents indicated that they actually target multiple domains simultaneously, and this is through the use of tasks that actually require multiple cognitive functions in real life. And some clinicians also say that they integrate cognition with other areas, such as psychological wellbeing or physical endurance. Measuring rehabilitation outcomes of cognitive rehabilitation was most common via attainment of goals, client or close other report or objective measures. However, only around 1/3 of our respondents actually used each of these. 2 main components of catering cognitive rehabilitation to the individual were identified. So firstly, majority did report adapting their practices to the client's cultural and linguistic background, with almost 70% of respondents having completed cultural awareness and competence training. Alongside this, individualising cognitive rehabilitation was commonly identified to occur through use of real-world settings, targeting activities or skills the client required or desired in their life, or tailoring strategies to the individual's needs. In regard to the context, cognitive rehabilitation was most frequently practiced individually, in person, in the hospital or clinic, closely followed by the community, whereas telehealth and group-based cognitive rehabilitation was less commonly used. And in regard to the team, occupational and therapists and speech pathologists were reported to be most routinely involved, and this was actually followed by physiotherapists and neuropsychologists. Now, promisingly, awareness and use of resources to aid cognitive rehabilitation was high. For example, over 90% of our respondents were aware of and used journal articles, and this was closely followed by clinical practice guidelines to aid their practice. But despite this, overall, only 44% of the clinicians actually felt sufficiently trained to undertake cognitive rehabilitation, so this leaves a large proportion who did not. And qualitatively, the clinicians also indicated that limited knowledge was impacting their delivery of cognitive rehabilitation, and they identified this as a challenging area of practice. Overall, there was a really clear message from the respondents. They wanted further training, resources, and opportunities to advance their practice. So overall, around 70% of our respondents did say that they were satisfied with cognitive rehabilitation delivery within their workplace. But to understand this, we wanted to identify facilitators and barriers at the level of the client, the clinician, and the service to cognitive rehabilitation practice and outcomes. And it was the service factors that appeared to pose the greatest challenges, so today I'll just focus on these. So at the service level, adequate time, funding and access to resources and services were noted to facilitate cognitive rehabilitation, along with a cohesive, consistent and interdisciplinary team. But despite these facilitators, majority actually indicated a lack of time to adequately support cognitive rehabilitation. Further, a lack of staffing or a lack of integration of the multidisciplinary team could also impede rehabilitation. Financial barriers for clients, and in particular, limited rehabilitation funding, were common issues for cognitive rehabilitation. Limitations of the setting itself were frequently noted, and for some, geographical access could actually limit access to these services. So I know that's a whirlwind of results, but I just briefly need to mention that our survey did have several limitations. So participants were, of course, those who were interested in cognitive rehabilitation. And we also didn't capture those who don't practice cognitive rehabilitation despite working in a TBI rehabilitation setting. There was high representation from Australian clinicians, although managed by the sensitivity analysis. And lastly, of course, the survey relied on self-report. So to sum up, in the context of previous surveys, there actually appears to be a number of advancements in awareness and resources of evidence-based practice, which is fantastic. But despite this progress, numerous challenges and barriers were identified. So ongoing efforts to bridge the knowledge to practice gap are required. Skills-based, sustainable and cost-effective capacity building opportunities are clearly required, considering the barriers identified. So to continue to improve practice, we must collaborate with our key stakeholders, including clinicians, administrators, individuals with a TBI and their close others, and this is the direction that this work is now headed in. So thank you very much.
Thanks, Jessica. We're going to hold questions till the end. And our next speaker is Professor Susan Hillier, who's a clinician and researcher in neuroscience and rehab at the University of South Australia. And she's going to talk about understanding quality in adult brain injury rehabilitation. Susan.
Thank you very much for the opportunity to speak to you today on this project. Firstly, I need to acknowledge my co-workers with this, Dr. Carolyn Murray and Julie Luca and Anthea Worley, and also the funding was from the Lifetime Support Authority. So if we've jumped. Let's go back. So the project was looking at quality indicators in traumatic brain injury rehabilitation. We had done a quick scan of the literature to find that there weren't any actually documented what would quality look like. So if we go this way, that one. What is quality? It's the standard of something, as measured against any other things of a similar kind, the degree of excellence of something. So it's a distinctive set of attributes or characteristics. In this instance, what we were looking at was what are these quality characteristics in brain injury rehabilitation. And we were interested in rehab, whether it was in inpatients, outpatients or community settings. So, and why do we want to know about quality? Well, the obvious answer to that is if you want to do quality improvement, you need to know what quality is in order to improve it, to get to that, in that direction, in that goal. But also, how do you, the tools to operationalise quality are really important. Otherwise, quality is in the eye of the beholder. So we gathered information from three main sources so that we weren't just thinking about our perceptions of quality. So the first phase was a scoping review where we looked at all the different ways of measuring and understanding quality in traumatic brain injury rehab. Then we gathered all that, and that was all synthesised into a big table and a whole lot of domains, which I'll go through in a minute, about what are the sort of consensus domains from a literature point of view. Then the second phase was we took that information, we used an EPOC framework to put that together, and we took it to semi-structured interviews with key stakeholders. Now, the stakeholders were people who'd had traumatic brain injury, caregivers, which were predominantly family members, and clinicians from local rehabilitation services. So we then I'm told, my technical term for this is we mushed that data together. I'm clearly not a qualitative researcher. I'd add things, but this was mushed. And we took the mushings to a vote, and we used a particular device called Waggle to get voting consensus on these, and we did that in 2 rounds. So we feel like we've got a pretty robust set of recommendations about what quality looks like from 3 clear perspectives in terms of lived experience, but also from the literature. So what did we find? Oh, that's merging. See, I call it mushing. I think mushing is a much better word. So the results were we found 64 studies that talked about quality, what quality would look like. How would you know quality if you bumped into it in a rehab centre? We had 7 people with brain injury, 8 caregivers and 7 clinicians, and then we did the voting. So I'm sorry about the small writing, but I think there's a lot of detail in here. And really my motivation, and thanks to Nick for offering this forum to talk to you about, is that we did some great work. The people who participated gave us some really deep insights into what quality is. And we've got these recommendations, and I'm really keen for people to contact me. So I'll leave these handouts outside with my email address and the final quality indicators to see how could we produce this in such a way that you could use it, either because you have a traumatic brain injury and you kind of want to check out rehab in terms of quality offerings. So it's like your personal audit, or whether clinicians and service providers here would like to use these. And we've also got an article coming out hopefully soon in brain injury that talks about the methodology behind it, but also gives you the quotes and the actual language that these quality indicators were expressed in our semi-structured interviews. So just briefly, on the left is the quality domains from the 64 studies. In the middle is the related coded groupings from our interview data, and then on the right is the consensus choices that went to vote. So if you've obviously had a read of that while I've been babbling on, so I'll just jump to the sort of data. Now, whether you can read that or not, but you can see the green is the accumulated votes for the final recommendations of what quality indicators should include. There's clinicians in the funny beige colour, carers in orange and clients in blue. And not surprisingly, we're not going to get consensus about this because everybody's got a unique perspective, and it's really important that that perspective is included. That all of the voices are in these documents. But you can see where the accumulated or the aggregated votes were particularly around rehab being individually tailored, focused on meaningful goals. A lot of the language that you were using is coming out here that's very generic across all aspects of rehab. Family involvement, attends to psychosocial needs as well as others, is motivating, optimistic and hopeful, that staff have rapport and they work together, that they know the clients well, that they have expert knowledge, that the staff are responsive, rehab is adaptable and thorough, it demonstrates improvement and so forth. So this is the document that I'll leave for people to pick up or that I can post to you, where what we think might be helpful is that if we have these domains that you can consider for your services or the service that you want to access or provide, either way, and that you can then put in your own language, but we've put in some guidance around that. So if the domain is, for example, effectiveness and efficiency, which was one of the top domains, the specifics that came out of the data for that were things like, as I mentioned, individually tailored, family involvement, motivating, optimistic and hopeful, and demonstrates improvement. How you could then operationalise that, I think, would make some very interesting QI kinds of projects, for teams to take on board. How would you know that you're doing that? How would you know? What would optimistic rehab look like? Things like staff attitudes, I think these would be great to put into your position descriptions. The knowledge and competence aspects, again, looking at what are you providing, how do you work together, how do you demonstrate knowledge, and then the coordination, the justice and the equity aspects were very strong as well, so that our services are equally equitable and accessible. communications, safety, so there's no physical, psychological or cultural risk for participants, adherence to standards, which we'll hear more about today, and of course a physical environment that's safe and accessible. So I'll leave it there. I really do hope to hear from you, because we don't want this work to sit in my office, because it will get very dusty there. We would really like to help translate this into your services and into tools that you could use to ensure that we are providing the best quality rehabilitation for the people that we care about. Thank you very much.
Thank you, Susan. So the next speaker is Liesel Jeffers from the Northern New South Wales Local District Health Service, and she is going to be speaking about getting consumer feedback about community rehabilitation.
Thank you. Hi everybody, I'm Liesel. I manage a number of specialist services in Northern New South Wales, and one of the services I manage is the Northern Brain Injury Rehabilitation Service. So we are part of New South Wales Health, so we work for the government. And today I'm going to tell you about a research project we undertook to improve the provision of specialist brain injury rehab in our region, being Northern New South Wales. So the NBRS, the Northern Brain Injury Service, is a small service that supports people who've sustained a new severe TBI. We cover an approximate 3-hour radius, and we support people in their home and community and via phone and virtual care. There are 15 brain injury rehab services scattered across New South Wales, metropolitan, rural and regional, and we all sit under a statewide clinical network, and the role of that network is to provide consistency in the criteria for entry and exit to the service, and also ensure that what we're providing is evidence-based care. Our service predominantly provides case management and neuropsychology assessment and intervention for people that are aged 16 to 65. And around 5 years ago, we strategically recruited 2 OT and speech positions, and that was one of the kickstarters to us exploring what more we could provide in our service. And in 2022, we embarked on a project to redesign our service model to address some of the problems that were experienced in our region. And we knew we wanted the solutions to be informed by our consumers, so our clients, their family members, our key stakeholders. And I guess when I talk about key stakeholders, a lot of those are people that provide a huge amount of generalist rehabilitation. Because we are a small service, we heavily rely on generalist services and also GPs and specialists. In New South Wales, over 100,000 people currently have a brain injury, and around 1,000 people each year sustain a TBI and experience long-term disability. In Australia, specialist rehab services for people with TBI are generally located in metropolitan areas and some larger regional centres, and we know there's less funding allocated to rural services, which have fewer staff than our metro counterparts, despite providing rehab for people who live many hours away and cover vast geographical areas. Mitch, Curtin and Badge in 2014 identified a number of key issues regarding provision of specialist brain injury rehab to people in rural and remote New South Wales. And some of those issues include limited access to appropriate brain injury rehab, difficulties funding, recruiting and retaining good skilled staff, and inadequate current services, which results in a number of unmet needs for patients. And those 3 things are certainly issues that we experience in Northern New South Wales. My service was designed in the 90s, and whilst what we provide is evidence-based, we know we can offer more, and we're fortunate to have highly skilled staff, those smaller numbers, but some of their skills are underutilised and limited by the predominantly case management model of care that we have. So we launched a research project, and the information gained from that research informed the redesign of our service model. The project used a methodology called the nominal group technique to facilitate a co-design approach. And we wanted to use co-design to identify the needs and preferences of patients and key stakeholders from a brain injury rehab service. Understanding the views and priorities of our patients and stakeholders is important, because people are likely to engage in a service that meets their needs. We engage patients, families, public and private healthcare professionals who support our patients in the generalist sector, the NDIS, insurers, medical staff, and other stakeholders in the co-design. And the research question we asked participants was, what are the most important features of a brain injury rehab service? Simple. In the redesign of our service model, it was important to balance best practice principles against context-sensitive considerations. And context for us meant things like consumer experience and their priorities for change, the local resources and finances, and geography. We completed a 3-stage process to ensure the redesign was well informed. So that included a literature review on best practices. We did a very detailed environmental scanning and benchmarking across New South Wales and Queensland with other brain injury rehab services to learn about their strengths, key initiatives, the types of interventions their speech and OTs were providing and the group interventions that they were carrying out. And as already discussed, the third component was the co-design. The co-design workshops generated 6 overarching themes, and these are the themes that you can see here. The themes became the guiding principles for our service in providing brain injury rehab and will continue to into the future. I should note that this started in 2022 and we're still going with this project. It was a huge change project and we're still very much in the implementation of it. So 5 minutes isn't doing it justice, but I'm doing my best today. So the themes, the enviro scanning and the literature reviews provide the information that we have to decide as a service now things like, are we achieving the themes? What should stay and what should go in our existing service model? And if we haven't achieved a particular area, how can we, what needs to occur, and what's the priority for its implementation? Okay, so the best part, the outcomes, the changes that we made. So the project has given us a wealth of practical information to make changes that we know will make a difference. And those listed here are just some of the many changes to the service model we have made or intend to make in the future. And you can see there, some are already implemented and some are planned for 2025 and 2025 onwards. Importantly, the project has brought about change in our patients and families, our healthcare colleagues and our own service, and we have clear priorities for what we'll address in the not too distant future. Hopefully I'll be back sometime to talk about those as well. So in summary, this project uses a 3-stage approach to ensure our service design was evidence-based, consumer-focused and had sound quality improvement processes. And my main reason to be here today was to show how research, big or small, can make an impact on the care we provide to our patients and their families, and more broadly, how we can support our colleagues to provide brain injury rehab as well. I hope it's generated some thoughts and inspiration today, and thanks for the opportunity to present.
Thanks, Liesel. Next up, we have Dr. Megan Topping, and she's a postdoctoral researcher at the Summer Foundation, and she's going to talk about bridging the gap, practical strategies for enhancing quality disability support grounded in lived experience. Megan.
Thanks, Mark. Hi, everyone. Thanks, great to see so many faces. So today I am talking about my PhD research and where we're going to next, so a little bit of an intro into that next stage of thinking about practical strategies and implications. Sorry. Before I start, I would also like to pay my respects to the Kaurna people as the traditional custodians of the lands on which we're meeting today. So as some background, people with disability have the right to receive quality disability support in line with the UN Convention on the Rights of Persons with Disability. And support is really vital to many people with disability to live the life that they want to live. However, we know from the recent Royal Commission and also the NDIS review that support quality is really variable in Australia. And I'm talking about support from paid disability support workers. So there's multiple players that contribute to the quality of support. And my PhD aimed to obtain the perspectives of a few of those key stakeholders to understand how to facilitate quality support in practice. And today I'll talk a little bit about how we're going to aim to bridge the gap between the theoretical model of quality support that we developed and how to facilitate quality support in practice. So this is an overview of my PhD project. So I started with a literature review to see what was already out there. There wasn't very much. We then conducted 3 constructivist grounded theory studies where we interviewed 12 adults with acquired neurological disability, 12 disability support workers, and 10 close others of people with neurological disability about what they think influenced the quality of support. We then brought these 3 perspectives together to develop a holistic model of the factors influencing the quality of support. And now we're in this next stage of research translation and how we inform practice and policy. So these are the 3 models we developed from each of the perspectives, and I won't go through them today, but they are all available open access if you're interested. And then, as I said, we analysed those 3 models together to develop a multi-level systems model, and that paper is published as well with the model that includes all the factors that people with lived experience felt influence the quality of support. So if you're going to pick one of the papers, I would pick that one to read. It has the kind of overview and it's grounded in the 3 perspectives as well. So once we had our model, we went back to our original data to reanalyze it, to extract all the practical strategies. We knew there was so much gold and we'd kind of abstracted it up to these factors that influence the quality of support. But we knew our participants had given us some really tangible ways in which you could do these factors in practice. So we sorted those strategies into 4 categories in this kind of cyclical timeline of the support experience for people. So starting with the red quadrant of the building the support team, so what you need to do to build a good support team, and then to training your support workers, the delivery of quality support, and finally that maintaining and improving support quality. And there were strategies in there for people with disability to use themselves, and also for support workers and service providers to help facilitate the quality of support. So in the interest of time, I'm just going to give some examples from one of the quadrants today. So I'm going to talk a little bit about the delivery of quality support. So these are mainly aimed at disability support workers, unsurprisingly. So the first of which is around making sure the role is right for you. So it came through really strongly in the research that it was really important to want to be a support worker. So people talked about the importance of ensuring you understand the role both at the broader level and also that for that specific individual, because it can look quite different for different people. And then seek out any relevant training, guidance, or experience that you might need to make that decision. Then there was the issue around demonstrating your commitment to the role. And people talked about being kind and maintaining a positive disposition, not complaining about your personal life. This came up a lot from participants. Being reliable and showing up on time, being committed, and taking that time to get to know the person and build trust. And in the delivery of support itself, it was really important to recognize that person as an individual. And ways to do that included proactively learning about the person and their specific needs, not making assumptions that might be on people you've supported before or someone's disability type, and treating the person with respect. And some examples of that were not speaking for the person or being condescending. Next, it was important to see the person as the expert in their own needs. So ask how they want to be supported. Actively listen and follow their instructions. and learn the person's communication style. Not everybody will be able to lead their supports in the moment, so ensuring that you're making an effort to learn how they can communicate that with you. And supporting people to live the life that they want to live and not acting as a barrier to that. And then prioritizing and focusing on that person. So being attentive, taking a flexible approach to the support you're providing, but also thinking ahead to foresee their needs and being proactive and able to respond to their needs. And then finally, in this section, there were some strategies for both people with disability and support workers and how they can build a quality relationship to work well together. So setting expectations at the outset of how you want to work together, being patient with one another, sharing feedback and having that open and honest communication, treating each other with respect and dignity. And also people talked about the balance of boundaries and friendship in the relationship, and that looked quite different for different people. So again, comes back to that open and honest communication and setting those expectations. So that was just one of those quadrants. I'm happy to chat more about the others, but just to close out on where we're going next. So we're now moving into the co-design phase of this project, where we're thinking about how we can work with people, key stakeholders, to design some practical solutions. And here are just some examples. So tools and resources to help people to lead their supports, professional development opportunities, some strategies to monitor the accountability of the support workforce, and finally, to develop a reliable and valid tool to measure the quality of support. And this could be used by people with disability themselves or by providers or support workers to engage in reflective practice, and also to evaluate interventions. We spend a lot of money on support for people, but there's no way to really evaluate the quality of it. So that would be really useful. So thank you.
Thank you. And finally, we have Cynthia Honan, who is a clinical neuropsychologist and senior lecturer from the University of Tasmania, and she's going to tell us about the development of the psychosocial guidelines.
Thanks very much, Jenny, and thank you for the introduction. I think it's an absolute privilege to be talking amongst these colleagues today about such an important topic, which is about the implementation of research findings into practice. And some of you would have heard this morning Mark's talk about the amazing work the Canadians have been doing in developing clinical practice guidelines for moderate to severe traumatic brain injury over there. But I'm going to talk to you today about some of the work we have been doing in Australia. This work is still in development, and it really will just be a snapshot of the work we have been doing. So we're developing some guidelines for the treatment of psychosocial difficulties in adults with moderate to severe traumatic brain injury. So when we talk about psychosocial functioning, we're talking about those processes involving behaviours, social functioning, emotional functioning that enable us to successfully communicate and interact with our environment. And often in people with TBI, it's difficulties in psychosocial functioning that are the most burdensome and long-lasting, and which requires the greatest amount of support long-term. But we also know that in recent years there's actually been a lot more studies being developed to evaluate effective treatments for these psychosocial difficulties. In particular, there's treatments being developed in the area of mental health, for example, cognitive behavioural therapy and acceptance and commitment therapy, but we also see there's a lot more studies coming out relating to treatments for behaviours of concern and social cognitive difficulties as well. But as Mark pointed out earlier in this session, it's very difficult for clinicians, health professionals to keep up to date with the latest research findings. So we identified that there was a need to translate some of this evidence in the literature on treatment effectiveness into practice. And one way that we can do this is to develop clinical practice guidelines. And what clinical practice guidelines are, if you missed this morning's talk, they are very rigorously developed recommendations for health professionals to help them improve outcomes, and in this case for people with moderate to severe TBI. And they're based on the evidence, but they're also informed by expert opinion, both by clinicians and health professionals, but also people with lived experience as well. So in recognition of this need for some Australian-based clinical practice guidelines, we set up a working group with the help of the MRFF, and we started with a steering committee which later developed into a technical team, a review subcommittee, and a broader, much larger development group of over 30 people. We went first through this exercise of defining the scope of the guidelines. The psychosocial difficulties is quite broad, so I won't talk about this entire process, but some of the more important things that we did was we conducted a survey both with clinicians and people with lived experience, just to try and ascertain what their priorities would be, in terms of, well, what difficulties should we cover in the guidelines, and whether we should be just focusing on treatments or other things, like should we also, detail how we should assess this. And we had a workshop too where we got together as a group to help finalise these priorities for the guidelines. We also looked at the literature as well, because there's no point having guidelines if there is nothing in the literature about how to treat certain conditions. So we had a look in the literature by conducting some scoping reviews. Our initial search identified almost 30,000 articles, but when we kind of drilled it down, we were left with a smaller set of relevant articles. So we found 70 plus in mental health, 50 plus in challenging behaviours, and around 20 in social cognition. So this is treatment for those difficulties. Just to give you a bit of an indication of what we did for the priority survey that we sent out, this is just one example of the findings we had from the clinician survey that we did. So we asked, which of these mental health difficulties should we prioritise, and you can see that obviously there was overwhelming support there for depression, but also for anxiety and suicidality and psychological distress, which ended up being part of the focus of the guidelines. So in a snapshot, this is the difficulties that our guidelines are covering, so it is quite extensive. Now, the next step that we started undertaking was to do some really detailed systematic reviews to evaluate the evidence. And because they're Australian-based guidelines, the National Health and Medical Research Council of Australia require that we undertake grade processes to evaluate the quality of the evidence, and that's quite a laborious process. And through that process, we then get together in panel meetings and we use an evidence to decision-making framework in order to start making recommendations in the guidelines. So this is just an example of one of the clinical questions that we had. Should cognitive behavioural therapy be used to treat mental health difficulties, including anxiety, depression, psychological distress and suicidality? Here you see there's actually 12 evidence to decision criteria that we talk about in our meetings. It starts off with the problem. Okay, so is anxiety, depression, etc., these things that are a problem and things that we should focus on. And then we talk about the desirable and undesirable effects, if there are any, with the treatment. And then we talk about, is equity an issue in terms of this treatment? Is it acceptable? Is it feasible, etc. And the end point, this is just one example of a recommendation. So we've, because there is actually some evidence, but it's limited evidence, we've made a conditional recommendation that adults with moderate to severe TBI, we do suggest that CBT is offered to treat mental health difficulties, and also accompanying that conditional recommendation, we make some good practice points, which is based again, on the research literature, but also clinician opinion as well, which is to enhance that conditional recommendation. All right, so just some takeaway points. One thing that's really important to note here is that clinical practice guidelines are really, really important. I worry about what's going to happen after we've finished these clinical practice guidelines. We need to try and turn these guidelines into living guidelines so the research can be updated for clinicians in the long term. There's still limited evidence out there for effective treatments. We need more evidence. We need more research directed to psychosocial functioning and to improve psychosocial functioning. The other thing too is that there's limited research and evidence for people with Aboriginal Torres Strait Islander people and culturally and linguistically diverse individuals as well. So there needs to be a lot more dedicated in that space as well. So I just wanted to thank this enormous team just for their dedication to this project. It's been a lot of hours of work, but we're